speakers today. Good morning, all my friends over here in India, and good evening to all those who are in the United States of America. And welcome to this 92nd episode of the continuing medical education programs being organized by Andhra Medical College, Visakhapatnam on COVID-19. We have seen a variety of presentations. In between, we had daily lectures when we were in deep trouble. And there was enormous knowledge that was gained by all the participants on this forum. And we've been trying to get all the postgraduates, particularly, and the junior consultants to log in and learn more. So I'm very glad that we had very illustrious speakers, and both Sridhar Chilamuri and Dr. Ram Kairam have taken on their shoulders the responsibility of not only identifying high quality speakers, but also moderating the session so that it makes sense and it makes the sessions more interesting. So, and apart from these two, Dr. Kalpalata Guntupalli was very instrumental in identifying some very good speakers for us, like Dr. Kulkarni. We had multiple sessions on various subjects, and we had repetition of some of the speakers also because they are so good that we wanted to have their opinion. And similarly, today we have Dr. Bush Kauru, who has been with us in Andhra Medical College about 3 years junior to us. And he was also there earlier speaking to us. We all liked him because the way he presents, as if he is talking to us as one-to-one contact. Being psychiatrist, he has got that. He has got that way of presentation so well. And today, even before Dr. Bush presents, we have an young lady by name Neelima Kottapudi. She'll be talking to us a little bit, maybe about 10 minutes on the vaccine hesitancy and acceptance, her viewpoint. And Dr. Ram Kairam will be introducing her as well as Dr. Bush to the audience. We will start with Dr. Kottapudi. May I ask Dr. Ram Kairam to introduce and let us know as to what she's going to talk to us about.
So, Neelima Kottapudi, some of you who have been regularly attending these sessions may remember her name and her face. About 5 months ago, 4 months ago, she asked questions regarding her father-in-law who was ill in Hyderabad. Around that time, there was a lack of clarity regarding how to manage acute COVID. She was very good in giving us follow-up over about 7 or 8 week period. And the discussions that came out of her questions allowed us to learn more about how to handle it, especially anticoagulation and ventilatory management, when to escalate oxygen delivery systems, etc. Neelima Kottapudi is not a graduate of Andhra Medical College. She went to Share Medicity Medical College in Hyderabad and then did an MD in ophthalmology. Because of marriage and husband location, she came to America. She is now waiting to do a residency. And for the last 5 months, she's been working in my office. You will see in a moment why I asked her to do this. And this happened because periodically I have talked about vaccine hesitancy, vaccine low acceptance, vaccine fear, and vaccine misinformation, worrying that when the vaccine becomes available, will enough people take it or not? This has come to a head because unvaccinated people, when they are infected, are the ones that contribute to variants, and unvaccinated people, when they become sick, they transmit the infection to children who are not vaccinated. So there is a possibility of disaster. So in that regard, because of the kind of practice I run, I talk to Neelima regularly, and she's going to share with you some information quickly. So, Neelima, proceed.
Thank you, Dr. Kairam and Dr. Sudhakar Reddy for giving me this opportunity. So today I would like to share my thoughts about COVID vaccination in children with neurodevelopmental disorders. Well, before that, just a quick look at the numbers. And according to the latest CDC data, as to October 15, 2021, the total number of cases accounted to about 240 million, and the total deaths are about 4.9 million all over the world. And United States in particular, the total number of cases are 45 million, out of which children constituted about 16% of the positive cases, and the deaths accounting to about 560. So in the next slide, I would like to emphasize about the importance of vaccination in these cases. Like, because of COVID, the number of deaths in children from the period of starting of the pandemic till date is 560, versus the number of deaths due to influenza in children less than 18 years of age is 1. All this can be achieved mainly because of regular flu shots and masking, and also hand sanitization procedures. And little information about the past history. With regards to measles vaccination. Before vaccination in 1963, the total number of cases per year were 500,000, whereas the total number of deaths were 500. But after vaccination, measles nearly was eliminated from US, the last death being reported in 2015. So now coming to the topic proper, I would like to discuss about the neurodevelopmental disorders, which are a diverse group of chronic conditions that impact functioning of a child throughout the life. And in 2015 to 2017, 1 in 6 children aged between 3 to 17 years of age had a developmental disability, such as cerebral palsy, autism, or intellectual disability. And among the US population of all the age groups, patients with COVID-19, especially those with autism, ADHD, etc., were 3 to 9 times higher, had a high likelihood of having hospitalized with COVID-19 infections. And the data that was collected on approximately 43,000 children less than 18 years of age from March 2020 to January 2021 showed that children with neurodevelopmental disorders were 1.6 times as likely to be hospitalized with COVID-19 infections. So what are the reasons for these increased incidence? First one would be associated medical conditions. Second would be barriers to accessing healthcare. Third would be limited mobility, especially in cases like cerebral palsy. And also the direct care requirements, wherein a primary care provider wherein a caregiver has to be present with the child 24/7. And given these pandemic conditions, it is quite difficult to imagine that. Apart from that, there could be challenges that can be faced while educating about the preventive measures, like educating them about wearing a mask or a face shield, and also educating them about the gravity of this infection given their limited cognition abilities. So all these are the reasons for increased incidence. While I was doing my research, I came across this article wherein there was an evidence from the first study of long-term COVID-19 in children in Italy that suggested that more than half of children between 6 to 16 years old who contract the virus have at least one symptom lasting more than 120 days, with 42.6% impaired by these symptoms during daily activities. So these symptoms could range from acute psychosis, transverse myelitis, optic neuritis, to cognitive dysfunction on a long-term basis. Next slide, please.
I ran into a bit of a problem with the slides. I lost my screen. 1 second. I'm so sorry.
Should I share my?
Yeah. Please proceed. Go ahead. I will reconnect on my cell phone, shut off the computer. Please proceed. Sorry, it never happened before.
No problem. Just a second.
Yeah.
You got it?
Yes.
Okay, proceed.
Okay. So what was the reason? So how can all this be prevented? Well, we all know the answer for this. It is vaccination. Now, based on the previous data on influenza vaccine that can be used to inform the potential challenges for COVID-19 vaccination among the children with these developmental disorders. But despite many children with these developmental disorders considered as high risk of contracting influenza infections or complications due to influenza, vaccination rates in this population was consistently low. Data from previous studies also suggested that children with autism had lower rates of influenza and related vaccinations. The reasons being parental hesitancy and parental hesitancy for vaccines. So what are the reasons for this suboptimal vaccination? Well, limited knowledge on behalf of the parents, as we discussed earlier, and barriers to accessing healthcare, and also vaccine hesitancy, not only among the parents, but also among the siblings of children with developmental disorders. Apart from this, there are some additional challenges, especially seen in children with autism. In a survey that was conducted in involving greater than 3,000 caregivers, it was noted that COVID-19 related disruption of services led to moderate to severe stress among these children suffering with autism and also in their caregivers. The percentage accounted to be around 72%. Not only that, another additional challenge is a modified remote learning option, wherein the schools completely shut down the in-person option. And also isolation and segregation of these children with developmental disabilities from their peers, despite of the IDEA law, that is nothing but Individuals with Disability Education Act, mandating their education to be continued in a less restrictive environment. So what can be done here? Encouraging the parents and the siblings greater than 12 years of age of all school-going children to be vaccinated, prioritizing adolescents aged 12 years to be vaccinated, advocating for vaccinating children as a medical community. It is our duty to educate them, and also employing or considering a homebound school program for immunosuppressed children, especially for the children with neurodevelopmental disorders. For example, in children with mitochondrial diseases, there is a high chance of permanent neurological disabilities if they contract a simple flu infection, and this could hold true for the SARS-CoV-2 infection as well. Then next comes the parental education, which is the most important one, and it has to be provided by trusted primary care providers who can work with parents to learn and also address specific concerns with vaccination. And here the role of a pediatrician is very important to tailor the needs for the COVID-19 vaccination and also successful implementation of vaccine as a collaborative effort, working with the providers, like working with behavior therapists or speech therapists or occupational therapists, because they specifically know the needs of these children with developmental disorders. Okay, this actually, lastly, I would like to focus on this slide. This actually, we came across an interesting interview that was given by Dr. Lipkin, who is a famous virologist and also a professor of epidemiology, professor of neurology and pathology at Columbia University. Before going further, I would like to talk a bit about him. He is actually an internationally recognized virologist who was, for his work with West Nile virus, MERS-CoV, SARS-CoV, chronic fatigue syndrome, myalgic encephalomyelitis, acute flaccid paralysis, and SARS-CoV-2 recently. He has actually earned the reputation of being called a master virus hunter for his speed and innovative methods of identifying new virus. Actually, after Dr. Cameron suggested a movie named Contagion, for which Dr. Lipkin was the scientific advisor, I knew his importance and in his role in hunting the new virus. So he is a pioneer and a legend in this field, and he warned India in an interview, saying that it did not have the COVID safety armor that is needed to fully reopen the country. citing the extremely low vaccinated population. According to him, less than 20% of the Indian population was vaccinated, and 30% of the population were under 18 years of age and were ineligible for vaccination. He also quoted that 30% of the infected population could face long-term complications, meaning this population could not might not have the acute symptoms of COVID, but they might have permanently crippling or disabling symptoms. Disabling symptoms like cognitive dysfunctions, fatigue, or shortness of breath in future. He also mentioned about an interesting aspect about circulating variants which did not have names but were a potential for transmission in India. He came up with an interesting vaccination strategy called ring vaccination strategy. He called for tracking and tracing exposed individuals. It actually was successfully implemented in India in past for eradicating smallpox. So what is ring vaccination strategy? It is nothing but vaccinating the close contacts of the confirmed patients as well as contacts of these close contacts. Not only that, he also emphasized about improvement of public health infrastructure and vaccine and also masking to be a very useful strategy to prevent transmission of this disease. So lastly, I would like to emphasize on a point, that is education. Educating the parents, educating the patients. As doctors, it is our primary duty to educate the patients, parents, grandparents, our immediate family about the importance of universal vaccination. And also, me being a mother of two and I have my family living in India, I am really scared of the third wave, impending third wave that is seen in future, that may be approaching in future. So friends, let's become aware of the policy of vaccination and also educate everyone. And finally, the gist of my presentation is, for children with developmental disabilities, it is really important for the parents and their siblings and the household members to receive universal vaccination so that these children can be protected. And also, lastly, I would like to add a point about the vaccine acceptance concept that has been repeatedly advocated by Dr. Kairam and Dr. Sudhakar Reddy, and I finally understood the importance of it now. So thank you so much for giving me this opportunity. Thank you.
It's a little bit off our regular path, but it's important to, when somebody like Lipkin or Fauci or Dr. Francis Collins speaks, it's important to pay attention. I am a news reader. Much damage has been done in this country, but not listening to people like that. So I have been very familiar with Dr. Lipkin's career for the last 25 years since he came to Columbia. And he has been an extraordinarily important scientist in this field. And he is expressing great fear for the next 3-4 months. Of course, in this medium, at this podium, we keep talking about the disease, how to take care of it, what drugs to use, and how to do anticoagulation. But it still will boil down back to prevention, vaccination. So thank you for sharing that with us. And you would want to add a word to all the senior people in this room. Whenever they hear about a developmentally disabled child, it's important to pay attention to his increased risk. Yes?
Yes.
So thank you very much for preparing that. Are there any quick questions for her? Or only one question?
Anybody can give insight about, probably Dr. Sudhakar can speak in terms of vaccination for children in India and in our Department of Pediatrics at King George Hospital.
From what I have been listening from him, children are not being vaccinated yet. And they concentrated on adults under 45, so that if parents are vaccinated, the children are put less at risk. So that was the theme for the last 2.5 months. Dr. Vijay Sekhar might know more, or Dr. Naveen might know more about what's going on as of today for children vaccination. Vijay Sekhar?
Yes, sir. Actually, in the first week of October, maybe around 2nd or so, the government of India, DCGI, has given approval for the children about 2 years.
About
2
to.
to 18 years are also given. That is the latest thing in India.
So Dr. Kavuru, that's great news. I see Dr. Sudhakar has his hand up. Are you there? All right. So,
Actually, set to clear, I think,
Yeah,
sir.
yeah.
Sir,
One
namaskaram,
minute.
sir.
Okay.
Namaskaram, sir.
Go ahead, sir. Dr. Naveen, you want to talk?
Sir, I think only the expert group has cleared this Bharat Biotech vaccine, sir. And the government is yet to, final nod is yet to be given, sir, for the Bharat Biotech co-vaccine for the 2+ years age group, sir. If I am right, I don't think it's yet cleared, sir. Only the
Yeah.
expert group proposed to the
Yeah.
government, sir.
Yeah, Naveen, let me clarify. The DGCI has permitted this particular vaccine, Covaxin, to be given from 2 years onwards, but the government has not included this in the schedule as yet. So the vaccination for children has not started, and soon it might start once government gives a nod. That is number one. Number two, I just want to ask Dr. Kothapudi as to the statistics that the Lipkin, Dr. Lipkin has stated, like, 20% in India, I did not know the source of his information. I think it appears too low. Definitely, we have to take the warning from experts like him. But at the same time, we have to be a little careful when we are talking about the statistics. I do not know the source of statistics for him. So that's my observation.
Actually, it's a newspaper interview, and also he was picked up by the TV studios. He works out of the School of Public Health at Columbia University that has been constantly using information from Johns Hopkins and WHO. So if it's not 20% in the entire population of the 1.3 whatever billion, it may be 22%, but it is relatively low. I think that's the point he was making. And by the time 50–60% of the population are vaccinated, we may be into next spring. So he considers this winter a still dangerous time for India. Of course, that doesn't help us because there's not enough vaccine available, right?
And by October 19th.
If I may say, right now I'm seeing in the COVID-19 update, at least 50% of population in India got at least one dose. And so the 50.2% at least got one dose, and fully vaccinated are 21%. That's what, according to this, I think data from the COVID on the Google, maybe it's from a combination of Johns Hopkins and other agencies. Just
well,
One more thing is, what does that 30% less than 18 would be ineligible means? Which is that category which would be ineligible? Those who are less than 18 years.
I don't know what is the meaning of it. Neelima, did you understand it? I think he was simply referring to the newspaper reporter from his interview.
Yes.
In other words, I suppose what it might mean is because of that age, they are not being given yet. But today we hear that they are giving above age 2. So let's say we all do not know the exact numbers. But the point he's making is we are not out of the woods yet.
Yes.
So by October 19th, India is going to reach a great milestone, sir. 100 crore vaccination. I think, sir, principal sir may correct, sir. By October 19th, 100 crore mark is being reached. That is what is being projected, sir. Thank you, sir. Thank you, sir.
Naveen, what matters is the percent of population, because sometimes people like me worry about the word crore. I've been gone so long, I cannot automatically always refer and convert the crores into millions. Forgive me for that. But I think we wanted to bring that newspaper interview from this illustrious man as a way of reminding everybody we are not out of trouble yet. Vaccine, vaccine, vaccine. Okay, thank you for allowing me to do that. Neelima, thank you very much for preparing that. So Dr. Sudhakar, we now go back to Dr. Kavuru.
Yeah, please go ahead.
For those of you who have not heard him before, Dr. Bush Kavuru had already spoken to us about 4.5 months ago, when things were very bad in India, when there were horror stories being heard about the manner in which some people died, more than one person dead in the same family, and incredible psychiatric, psychological burden caused by this disease. He spoke to us at that time. I called him back to say that things seem to have quietened down, but still there are many issues related to the consequences of this terrible disease, both on the survivors and the family members, and even the longer term consequences of death, especially multiple deaths, and this so-called long COVID syndrome as it relates to psychological and psychiatric manifestations. So he was kind enough to agree to come back to talk to us. So Dr. Bush, the audience is all yours.
Thank you, Dr. Kairam, and thank you, Dr. Sudhakar. It's just very inspiring and to hear that Dr. Sudhakar and his team at Andhra Medical College, and hear Dr. Kairam and his team and the AMCANA are doing this and helping everybody to gain more knowledge in handling this. I myself, I work in outpatient psychiatry, and I also work with the internal medicine department, and I deal with mental health issues in medical population. And I also work with a lot of veterans who are having post-traumatic stress disorder. And I wanted to focus on some of these mental health issues or psychosomatic issues, and from the psychosomatic perspective for the long COVID. When Dr. Kairam wanted me to speak about it roughly a month ago, we are seeing some of these patients who are coming back after the long COVID. But I didn't have any clear-cut idea how the demographics works within India, because we cannot always compare. So I have taken the initiative, and I did a small pilot study predominantly in with friends and family I know in Andhra, Telangana, and Bangalore areas. I would like to share the data. Going forward, when we say long COVID, and this is updating myself and others, that once we cross the 12-week period, and if the symptoms are there, and if there's no other diagnosis we can give, they're calling what you call post-COVID syndrome. And this is coming from the UK. And so right now we have here up to 3.2 million Americans probably are having this long haul COVID symptoms. And overall, they're saying if you take 100, minimum 10 of the survivors will develop long COVID. And many millions are possible in India. And I think one of the recent study from Asian Institute of Gastroenterology, they're saying at least we may have a 1 crore of patients in India who may be having long COVID. So with related to COVID, again, 6 months after contracting the COVID, roughly they're saying third of the COVID-19 patients be diagnosed with some neurological or psychological symptoms like anxiety, depression, and PTSD. So talking about what is happening in India is, this is one study from Northern India by Dr. Budiraja. They have this big private hospital, and they have telephone interviewed or two-step telephone interview of 990 patients, roughly 1,000. And after 3 months of recovering, 32% had COVID symptoms, post-COVID symptoms. And after 8 to 12 months, up to 11% of the initial group, they had some form of symptoms. And they reported the common thing they found is the fatigue and also myalgias. And they also came with some depression, anxiety, sleep, brain fog, etc. But they said they did not hear any reports, at least no severe organ damage. So this is one study I came across, actually. This gathered from Times of India newspaper. And they said they're going to publish this, but I didn't find the journal where it was published. The next study, as I mentioned, is from Hyderabad, India. This is very reputed institute, most of you know. So they actually surveyed up to 5,000 post-COVID survivors. And they said up to 2,000 had hospital visits just due to the post-COVID. And up to 41% of them had fatigue and body pains. And the interesting thing about it is, even with the mild COVID infection, 50% of the sample had post-COVID symptoms. I think Dr. Neelima was mentioning in her talk also that the other, the COVID specialist, Dr. Lipkin, mentioning about the risk of COVID, post-COVID symptoms, even with people who had a mild COVID infection. And this authors of Asian Institute of Gastroenterology, they said they found some correlation between irrational use of steroids in post-COVID complications and higher risk of long COVID. So these are the two studies I came across recently. Then while I was reading about it and saying, they said this is going to be the next public health disaster all over the world, not only in any particular country. And most of them have probably, this is similar to what we had before post-infectious chronic disease syndromes like chronic fatigue syndrome, or myalgic encephalitis. And Dr. Lipkin was one of the pioneers in that too. And they're saying probably the average patient of COVID would be around 40. So coming to what I wanted to learn, what's happening in Visakhapatnam or in our Andhra, Telangana area. I just did an anonymous Google survey, and I have, in the last 3-4 weeks, I have 75 people responded to it. And I also offered that I would like to talk to them if they have any questions. And I also did some patient interviews personally. And most of them are from AP, Telangana, and Karnataka. And the findings is that, first of all, I have added a couple of questions to the typical COVID symptoms, long COVID symptoms. I added loss of interest in fun activities, because this is one of these symptoms we ask for depression. It's a screening question. The second thing is feeling worried or irritated. This is the second one, which is actually a screening question for anxiety and sleep problems. And I collected the age and the sex of it. So these are all the symptoms I've asked. So I will try to share. So age ranges is, I have more people above 50, and some are between 20 to 50 or around 15. Total responses are 75, but because of the Google Forms, there was some confusion. That's why I'm showing less number here. So I asked people to share free responses, what is bothering them while they're recovering from the COVID. These are all these reports I have. Some people said their blood sugars are going up and down. Some people have said they have chronic cough. And some of them said they're frightened when looking at pictures of the COVID. And some of them reported feeling drowsy, tiredness, frustration, etc. And also depression, anxiety, and hair loss. So this is what I have: more men who responded to the survey than the women. up to 65% are males. And this is interesting. I found hair loss as a common complaint. Almost close to 50% of the people. And it's mostly hair shedding than hair loss, because after any viral infection, one of the phases of the growth of the hair, they will lose a lot. So the hair shedding is the phenomena, and usually up to 6 to 7 months it can continue, but then it will become normal. And the interesting thing, what I was hearing is, especially from the young ladies who lost the hair, they were feeling anxious and they're worried, and it's one of the cause for their worry. It's not that they're having any anxiety or anything like that, but that was something really they're bothered. The other thing, the major symptom is that feeling tired and fatigue. And this is where I think nowadays long COVID probably is like a chronic fatigue syndrome. And I think Dr. Kairam probably can talk about, from the neurological point of view, how it presented to them over the years with other chronic viral infections. And so I think this is the common symptom. Also here, even though I have small sample, even with Dr. Reddy's of Asian Institute of Gastroenterology, they also found the fatigue as the major symptom of this post-COVID. Again, this is about the depression. This is a screening question for depression. And I found up to 30% of the people responded have reported. And I would like to share that even the anxiety is also around 30%. And the interesting thing is memory concentration problems is also around 30%. And when I was looking at the data, people who had a lot of fatigue and myalgias, they were also more depressed and more anxious. So it is presenting with fatigue, tiredness, which is making them more disappointed why they're not able to do what the things they were doing before, and getting irritated, and they're getting anxious. And the important thing is that when I did some personal interviews, it is the family members who are recognizing this. If the husband is getting more irritated and angry, they're saying since he got the COVID, he's like, walking around the eggshells in the house. Same thing, the husband would say that she became more irritable, she's more depressed, yelling more, something like that. So it's not any gender variation, but both men and women, they have reported that. Again, some of them are reported sleep problems, and it's whether initial insomnia or middle insomnia or terminal insomnia, we did not collect that information. But again, people who were depressed and anxious also had these sleep problems. Shortness of breath is only 16% of the responders who mentioned it. And again, joint pains, 35% mentioned, fatigue and joint pains also. Muscle pains, again, 23%. Chest pain is only around 9.3%. And rapid heartbeat up to 11.6%. Headache up to 23%. Loss of smell or taste, I have only up to 14% who reported that. Dizziness is the last symptom I collected, that would up to 16%. So with this brief survey, my common observations were that majority of the patient had a fatigue, hair loss. They also expressed anxiety, depression, and sleep problems. And there are more responders with multiple somatic symptoms had expressed anxiety and depression, because some of them had diabetes, hypertension, even before the COVID. And people who had pre-existing anxiety and panic attacks, they said it got worsened. And people who had a difficult quarantine experience, they were reporting more of a depression, anxiety as a part of the recovery. I spoke to a couple. The wife had no problems. Actually, she enjoyed the quarantine, watching videos, and family were feeding her. She said, I had no problem. I did have minimal symptoms. I enjoyed my quarantine. Her husband has a so tough time that he was irritable, angry. He want to get out of the room, and he had more tough time. And post-COVID, he's the one still having poor appetite, and he still feels a lot of anxiety. So this is something interesting I'm hearing. Probably many of our experienced colleagues in Visakhapatnam care can share their experiences if they're seeing the same thing or not. And also I heard that women reported missing periods up to 4 to 6 months after the COVID. And before that, they did not have any kind of menstrual problems like that. So this is about the small pilot I've done and what I gathered. Now, the reason I have done this is because we don't know much about this. Because when I was working in community mental health in late 2000s, we used to see a lot of chronic fatigue and fibromyalgia. And they would come to me reporting anxiety and depression, that they're not having any quality of life. And as a psychiatrist, I would treat their anxiety and depression probably with an antidepressants and SSRI, and probably advise them some kind of a lifestyle changes like that. But their main thing was nobody able to give me a diagnosis. And they said sometimes, hey, my doctor did all the testing, they didn't find anything, and so they're lost. So here with the long COVID, do we have any biomarker? We don't, except for one of these UK multi-center studies said they found post-COVID CRP more than 5 milligram in 22% of the COVID cohort, suggesting it could be a persistent systemic inflammation. Otherwise, there's no accepted test right now to say whether they have a long haul COVID. And again, they're saying these symptoms are not like, viral myocarditis or any other direct symptom we can link it with. And some of the hypothesis possible is that it could be a persistent virus, and it could be disturbance in the autonomic nervous system, or it could be autoimmune. So what challenges we are having while we are seeing these patients who recovered is that I have a patient who is a nurse, and this guy had COVID twice, and he was working in the night shift. And he went back and he realized he was not able to do the same nursing duty he was doing before. And he said that I got slow, and I was not able to rather focus and remember all the tablets or the injections I have to give. I have to write it down. But when he went to the primary care, they said, basically, you have recovered from the COVID and we don't have anything. And you got your vaccinations and nothing much could be done. And he says that now I am stuck. They said, I got the COVID and I have no problem with acute COVID, but I'm not able to go back to work. And so he came to me, and then I don't know much about the long COVID. This is at least by the time we were going through the acute phase, and now people are coming back with these symptoms. So I have to look at him in a more perspective of a chronic fatigue syndrome approach. And finally, with this patient, I have to write to him that to work in a light duty. And then he worked with his bosses, and he took a different kind of a shift to work. So it was difficult for me as a clinician to how to work with this long COVID patient. And he had 2 back-to-back episodes of the COVID, and he never had any problems. And suddenly his whole professional outlook has changed. He said, I was proud of being a nurse, but I'm not able to do that right now. And I don't know what is my future. So that's a challenging patient. Now, I have to tell him, hey, this is a new normal for you. You are upset about what happened, but at the same time, you need to look, you are 45 and you're not going to retire immediately. So let's work together looking forward, what normalcy you can get to. And when he went to the doctors, the cardiologist and other people who has treated him when he was acute COVID, they gave all the treatment they could do. But when he went as a post-COVID, they said probably it is psychosomatic. And there were other patients, sometimes they were said, well, it's more psychological, things will get better for you. So when they start hearing it, there is a possibility that they may not go to the doctors telling that, hey, I am having all these problems. Unexplained chronic fatigue, unexplained chronic muscle aches, unexplained sleep problems, and irritability, and all these things would be the ones which probably they will go to a primary care. I don't think anybody want to go to a psychiatrist saying that, hey, I'm having some mental health issues, because this is mostly linked with stigma also. And this is something I work in the, as I mentioned, with the primary care and mental health integration. So I always talk to my physician assistants, nurse practitioners, and primary care physicians. Hey, if you're screening for depression, if you're screening for anxiety, if you have a long COVID patient, let me know. And tell them that I'm in your office. I'm sharing a room in the medical floor, so that they don't have to feel they're going to mental health clinic and seeing a psychiatrist. Now I caught the COVID, now you tell I'm getting crazy. No, that's not the issue. If you have issues, we have somebody who is in the clinic, who is a psychiatrist, who will be willing to talk to you and probably can give you some answers related to the symptoms. So that is the challenge in terms of handling the COVID issue from the patient side, and it's also from the provider side. So these are all the pitfalls I think happened with the chronic fatigue syndrome, possibly can happen with the long COVID, because we have a cohort in the last 2 years, children, college-going students, retiring physicians, young physicians. So we're all as a cohort. And I think for coming 5 to 6 years, maybe beyond this, there will be some people, at least as we say, maybe 5 to 10% of the population who may carry these long-term effects of the COVID. Now, as physicians, it is our duty to understand them well, not to miss a diagnosis, and we have to rather develop more insight into this so that we want to believe our patients when they complain, and not to rather sidetrack them or put them aside. You don't want them to get marginalized. One of the concerns is that because of our system is so disease and system specific, cardiology, neurology, respiratory, gastroenterology, we are not having a holistic approach. And there is a chance that these people will fall in the cracks in between. And I think most of the burden will be on the primary care and internist, because that's where they go for their care for hypertension, diabetes, and probably, I think, as we go forward, we'll have more knowledge and we can have some kind of a protocols how to handle this in the primary care level. So what are the mental health presentations? Over the last 6 months, I have seen anniversary reactions. Again, there are families now who has lost loved ones due to COVID. It happened in our close families, in our colleagues. And when this anniversary is coming, a lot of anxiety, a lot of depression. And this is something important. And I have realized that culturally, we have some protection in India, because we do our annual ceremonies. I think I have seen people doing their monthly, ceremonies. They do annual ceremonies and going to kind of in a Benares and doing those rituals. That is giving a kind of an outlet for them to kind of find a closure, because when COVID happened, a lot of people, when they lost lives, even they could not bury their loved ones. And that was very traumatic, especially for young children and who lost their young father. And now there is no way of closure. During these anniversary reactions, I'm seeing there is some closure they're able to find out. Now, how much we can capture clinically, unless you look for it, they won't tell you. But I think an advantage we have in our culture is that there are outlets for that to happen. But as a part of the post-COVID, because this is a pandemic, there will be millions of people. Do we have that kind of an plan and organization to address these anniversary reactions and grief reactions? Sure. How we can do is probably through the support groups. And I think any hospital system can have one or two people who are interested in these aspects. It could be a psychologist or a social worker, run some support groups. Also identify some local cultural coping factors which can help them. The other thing is that when I spoke to my other psychiatric friends in India, they are seeing new episodes of major depression and new onset anxiety and panic as a part of the post-COVID. And some of them also presented with obsessive compulsive related to cleaning, wearing the masks, and excessive obsessiveness about fear of contamination, fear of catching the COVID, to the point it is affecting their working, affecting their personal relationships. So most of us have these fears. If somebody is coughing, we're afraid, and we're always wearing the mask. And clearing the throat sometimes is more difficult nowadays. If you're in a group, you need to tell them, hey, I'm just clearing my throat, don't get upset about it. Now, but if it's affecting our function, if I'm not able to go to work, and if it is affecting my relationship or my social function, then we will call it a problem. So one thing is that any worry about COVID or a little bit of sadness or feeling crying once in a while, they're not having any mental health issues. These are all some of the natural reactions. So when can we say something is really somebody needs a psychiatric consultation, or who needs more attention would be if the family member feels this has really changed, this is causing a problem. Or a person says that I'm not able to go and perform my work. So those are the situations you want to give more importance in terms of more of a clinical evaluation for them. So this is the screen basically, because honestly to say, personally speaking, I lost a cousin. And I was on the phone helping to get him to the hospital, but we lost him within 24 to 48 hours. The sad thing is, there was a photo taken after he passed away. And immediately I looked at the photo and I could not look at it again. I removed it. But even till today, when I think of this guy, that photo comes to my mind. And it is, and just 1 year ago it happened. I personally feel that grief also, but I can process it and I can get over, move on, but not everybody can do that. So sometimes people may be having, see, I would do is that I translated this into Telugu. So if I'm asking somebody, పీడకలు రావడం కానీ ఆ కోవిడ్ గురించి ఆలోచిద్దాం అనుకున్నా సరే ఆలోచనలు మళ్ళీ వస్తున్నాయా? ఓకే, అలాగ వస్తున్నాయి, పీడకలు వస్తున్నాయి అనుకున్నా, లేకపోతే ఇటువంటి ఆలోచనలు రాకుండా ఉండడానికి ఇవి గుర్తు తెచ్చే విషయాలు ఏమైనా ఉంటే వీటికి దూరంగా ఉండే ప్రయత్నం చేస్తున్నారంటే, ఆర్ యూ ట్రైంగ్ టు అవాయిడ్ థింకింగ్ అబౌట్ ఇట్? Are you avoiding, like, you know, if you have a family member dead in a hospital, are you avoiding going there for further care? And if somebody had contacted COVID somewhere in a mall, are you avoiding going there? ఎప్పుడు భయంతో ఉంటున్నారు, వచ్చేస్తుందేమో కోవిడ్ వస్తుందేమో భయంతో ఉంటున్నారా? అలాగే అట్ ది సేమ్ టైం బీయింగ్ అవే ఫ్రమ్ పీపుల్, పట్టినట్టుగా ఉండడం, డిటాచ్మెంట్ ఫీలింగ్స్ ఉన్నా. లేదు అంటే అయ్యో ఐ డన్ మిస్టేక్, ఐ కుడ్ హ్యావ్ డన్ దిస్, ఈ విధంగా చేసి ఉంటే బాగుండు, ఆ విధంగా చేసి ఉంటే బాగుండు అని గిల్టీ ఫీలింగ్స్తో ఉంటే, ఇఫ్ యూ హ్యావ్ ఎనీ ఆఫ్ దెమ్, మోర్ దెన్ 4 కనుక ఉంటే, దిస్ ఈస్ సంథింగ్ you want to give some importance to it. This is called post-traumatic stress disorder screen. For the primary care, we do it. And I think definitely there will be some population, if you look at it, who would be able to, who probably will present this way. So what I do when I see these kind of patients in a internal medicine department is that I screen for depression, basically 2 questions. Do you feel depressed, or did you lose interest in pleasurable activities? ఏం పని చేయడానికి సరదా ఉండట్లేదు, ఇప్పుడు ఏదో ఉదాసీనతో ఉన్నాం అని వాడు చెప్పాడంటే probably you need to go a little bit more deeper into it. Same thing for anxiety and PTSD. And when have these kind of patients, especially in a integrated clinic, I try to talk to the social worker, and I'm a consulting psychiatrist, and we have a psychologist. So we try to look at patient from the multidisciplinary approach and try to help them out. So, but some of the things I share is that I will tell you some of the apps I have been using it, but this is the typical, like, management of the fatigue. Like in a chronic fatigue syndrome patients, we used to give them graded exercises and yoga and going for a walk and stretching if their fatigue is their main complaint as a part of the long COVID. And then is how to relax and manage their irritability and anger. And if they're having any issues, breathing techniques, if they're having a panic attack, and then the medications. I think nowadays people are trying to use some stimulants, what we use for people with ADHD, because the brain fog is one of the issues, and poor attention is one of the issues. And we use stimulants. We use stimulants for children and adults when you're treating that. So methylphenidate or amphetamines are also used. And I have used modafinil in patients who reported fatigue, apathy, sedation, and tiredness, especially in patients with depression, especially some elderly population. I'm not sure whether modafinil anybody has tried in the long COVID symptoms or not, but if something is an optional. And again, if they're having severe anxiety or depression, we can use in SSRIs. Now, we don't have any kind of guidelines. These are all the medications we have used in treating the major psychiatric illness like depression and anxiety. And we are trying to use the same things with the post-COVID and kind of see whether that would work or not. Now, you all can share this with the patients and the families. There is an app called CBTI Coach. This is available for iPhone and also for an Android. And they have techniques like how to relax, winding down techniques. And one thing I like is the schedule of worry time. If somebody is going to bed at 10 o'clock, I'm not able to sleep, I'm worried about everything. They say that have a scheduled worry time before you go to bed, and to say what I want to worry, write them down. And before then you go to the bed, it makes you feel, okay, I already took care of it, and that helps a little bit. And there are other applications in the CBTI Coach, how to change your perspective about things, and breathing tools, and some meditations also, and also progressive muscle relaxation. So I would encourage cognitive behavioral therapy insomnia coach, but it's not only just for people with insomnia. Some of these techniques are helpful even people with anxiety and depression too. So I would strongly recommend, this is free, anybody can download, it is CBTI Coach. Another is the University of California, their Mindfulness App. It is also available free on iPhones and also on Androids. They have very good basic meditations and wellness meditations and cultivating patience. So patients with the long COVID, if they're coming with anxiety, depression, fatiguability, irritability, we may not be able to right now give them a prescription and try it, but these are all the things we can. And definitely now we have a lot of organizations which are encouraging meditations, and we have a lot of groups who are encouraging yoga. So I think we have to look at all those locally available things and adopt them as a part of the treatment plan. And probably translating some of these things into local language will be also good. So this is what I have in terms of sharing with the shares, with the slides. And I think one patient, as I mentioned, is a 50-year-old, and he had anxiety and depression before, And he's the one who had a very rough kind of a quarantine. And but his wife, she also had COVID, but she did not have any problem. And so various presentations are there. And the main thing is our ability to identify and rather focus on them, because acute situations we're all very good, because probably had so many lectures on how to manage the pulmonary, cardiac and neurological, all other problems. But now the COVID will be gone, and I think I think we are lucky that in India cases are much less. But going forward for coming 5 years, I think each one of us will be seeing these patients. Do we focus on them, or we let them go, hey, I think things are going to be all right? Or we say, well, do this, do that. And will they get back their life or not? That is an issue. Not only this long COVID, there are other issues. For example, there are people whose education was really got affected. If you are an engineer, if you're a doctor, and if you really wanted to get to the school and you missed because of the COVID, you couldn't get to med school, you couldn't get to engineering, or you couldn't get a job. This will have an effect on them. This is not directly post-COVID, but I say COVID era related issues will have some mental health issues too. Dr. Kairam, at this point, I think I would like to invite any questions for the discussion, or if you have any case or anybody has any case, I want to hear from other faculty there. Dr. Naveen, probably they're all seeing these patients now. You're muted, Dr. Kairam.
As we wait for somebody to come up with a question or a comment, I do want to tell you something that struck me very hard from your study. You used in the end of the slides related to your pilot study, you had a very important paragraph for me where you mentioned people who are misunderstood, misdiagnosed, disbelieved, and marginalized.
Yes, sir.
In the medical system where a patient gets only a few minutes, if the physician did not know the extent of the disorder, he may not believe, and such people get marginalized and not paid attention to. When you were telling me that, what hit me was, long before the whole world found out about post-concussive syndrome from football injury, in the previous 10, 20 years, people did not understand enough about post-concussive syndrome. About 25 years ago, I happened to be in Washington, D.C., and I listened to a man talking about the Humpty Dumpty syndrome. He had a head injury, and it took about a week before he went back to work. And over the next 1.5 years, he visited about 6 doctors, 2 psychologists, and another therapist, etc. But he was not able to explain adequately what he was not able to do in the office. So he was not believed. He was basically, they threatened to fire him. They marginalized him. And eventually, after about 25 months, it cleared up. In post-concussive syndrome, that happens. But until such a time, for the person, it is real. For the family, the wife, the father, or the doctor, it is not. They can't completely understand. So I am just speculating. We are going to be hearing this. We're going to be hearing from all those people that are actually suffering, but because there is no objective sign, there's nothing on imaging, nothing on EEG, it may not be difficult to believe. So it's a good time to remind people, at least listen to the guy and see what you can do about identifying what is causing his discomfort. And it might bring out underlying anxiety and depression, but I think this disease is here with us to stay in some decreasing degree of severity. So I just wanted to remind everybody about how people with post-concussive syndromes are misunderstood. I'm going to use your paragraph for myself in the future. Thank you. Now, yeah, sorry, go ahead.
No, Dr. Naveen looks like he raised his hand. He wanted to say something.
Yeah, can you hear me, Dr. Bush?
Yes, Dr. Naveen Kumar.
I'm from steel plant. You know that I deal with a lot of industrial patients and I have a lot of follow-up. But the biggest problem, as you rightly said, was the loss of hair. People are worried, especially females. The incidence is almost as high as me. Without asking, 50% of them tell that they have hair loss, and another 20 to 30% usually have. Means when you ask them a leading question, they're really worried about their weight loss. Hair loss. And the second component is myalgia and fatigue. Now, we do not have a marker or a definite indication to say to what extent these people have this myalgia or fatigue. So that's another aspect which we are not able to quantify. And really, that's the reason why we are not able to give definite medication. The third component is the sleep disorder. Most of my patients have a lot of sleep disorders. During the initial acute phase, I used a lot of melatonin. I do not know whether it acted as a placebo, but most of them had relief. Well, your idea about modafinil is a good one. I didn't think of it, but I don't know what is the experience of people with modafinil. But this is, yeah, please.
No, go ahead, Naveen. Go ahead.
And finally, I thought you should have, you never talked about the psychosocial implications from a doctor point of view. I mean, a lot of doctors have this post-COVID syndrome, a long COVID, because the trauma of the patients that they had gone through during the first and the second wave. And it's really telling on the doctors. So if you can dwell a little more on that, or any studies done on them.
I think you're right, Naveen. We're all part of it. We are the victims too. It is not just the patients. And as you said, we would have the trauma. We will have the post-traumatic stress disorder too. Only one thing is we may have an insight. I would rather say we need to have at least some kind of a support network. Probably what we do in India is that we have a good number of friends. Among ourselves, we talk about it and try to share and get some kind of a relief or emotional support. One thing is there are a couple of aspects for this kind of a thing, is that not to deny the trauma, but accept and talk about it. Because we don't want to talk about what happened, the bad things, but you don't want to have to go into the details about it. So acknowledging what has happened and rather share with somebody whom you feel trustworthy and they don't judge you, and then commit that I suffered it. And at this point, my goal is to moving forward. I will accept, and it is difficult to completely accept it, but whatever happened is happened. I remember, I'm not going to ignore it. I'm not going to deny it. If it comes, it will come in front of me, and I will discuss with somebody whom I trust. And then I will commit for further progress, because that is the goal we have, all of us. I think probably, actually, Dr. Kairam was telling yesterday, there is one of the doctors who really wanted to look at this physician trauma in terms of while serving COVID patients and going through that pandemic. And but Naveen, so far, I haven't come across any study, but I would say support groups. Honestly, to do is that we need to have a support group where nobody is an expert in this, but at the same time, we can help each other, kind of a thing. With the modafinil, it works through the orexin system, basically. It is a dopamine reuptake inhibitor. It makes more dopamine available. And it keeps you more awake, especially with people with brain fog or sedation, and with fatigability and tiredness. I would use modafinil. I used to call FATs. Fatigue, apathy, depression, and sedation. Especially I used it in elderly patients, like failure to thrive, those kind of situations. But methylphenidate, Ritalin, what we call in children, nowadays, because attention problems, if you can capture in patients with brain fog, what we call it, you may have this thing. For hair loss, I was reading the American Dermatological Association. They said, don't worry, it may go until 6 to 8 months, but it will come. They're called telogen efflavum, I think. That's what they call hair shedding. It is not hair loss, hair shedding.
Yes. Yeah, very true. That's what we just tell the patient that you wait, but these patients are really impatient that they're losing a lot of hair. I want you to take on what is the role of melatonin in such patients who have only just the sleep disorder, nothing else, no stress, means no other symptoms.
Yeah, melatonin is non-addictive, and you can give 1 milligram, 2 milligram, 3 milligram, up to 9 milligrams too, but it does work in low doses. And if you have patients who are not having any substance abuse issues, and if you think they're not having any addictive issues, you can still use zolpidem, which is zolpidem. It is a 5 milligram, 10 milligram. And I tell them to take it as a needed basis, and it is calming. And if you are having patients with a lot of anxiety, and restlessness, and to take the edge off, if they're not having issues with any brain fog, I may use quetiapine, low dose quetiapine, 25 milligrams, only as a needed basis, not to take it regularly, because it is seen as a major tranquilizer for schizophrenia, but most of us use it for a non-schizophrenic indication, like 25 milligram, maybe at night. It's not on a regular basis, maybe for a couple of weeks, and see if it helps, then hey, don't take it every day, take it as needed. And if they're taking beyond 3 months, I would probably taper that out.
Okay, fine, thank you.
Okay, we have one more question from the audience. Raise your hand. Go ahead, sir. I only know you as the iPad.
You're muted, buddy. You have to unmute yourself.
You have to unmute yourself. Unmute yourself. Click. Can you please unmute yourself? Yes.
Yeah, now
yes. I am Dr. V. Sachananda, your brother's classmate.
Hi, Sachananda. Good to see you, sir.
Yeah, among the COVID sequelae, psychosomatic diseases, how many people have a comorbidity of psychosomatic, fast history of psychosomatic disease treated?
I don't have the numbers, but probably if you take it as general population wise, there will be a good number. And if you have psychosomatic issues, there is a reason, there is a possibility they could exacerbate it. And but in the post-COVID, before, if they're complaining of headache, like, multiple body pains, that's okay. But if they're complaining of fatigue, then this is different from that. That's where we need to pay more attention, because they were having a lot of psychosomatic issues before COVID. And now they're complaining the same thing. I don't want it to rather say this is an old phenomena. Still, I would look at them and see, is there any change in the symptomatology? Definitely, as I mentioned, people with anxiety, panic attacks, they can get worse post-COVID. And the management probably related to anxiety and depression may not change much, because we only know what we have in our hand to use it. Until unless there is a new pathophysiology, like, people talking about central immune issues and inflammatory cytokines at the level of brain, which may be responsible for these psychosomatic symptoms like fatigue and muscle pains and tiredness for that. But right now, there will be good, but I don't have a number for that, Sachinanda.
Thank you.
While you are still on that topic, I have a question and a suggestion to you, Dr. Kavuru. If you continue your survey, you had said about half of the people in the post-COVID syndrome reported lots of symptoms that were listed. The other half who did not. I'm asking you if you're curious about why not. In other words, are these the people who are already practicing yoga, breathing exercises? They knew something about self-relaxation techniques. Do they do pranayama? What kind of individuals could avoid these symptoms? Because in order to think that these kind of techniques will help, it would be interesting to see if a practitioner of those techniques did not develop the post-COVID syndrome. Not easy to study. I'm suggesting that it is something to think about because everybody is recommending relaxation techniques, pranayama, breathing exercises, yoga, meditation. It's not that easy. Most people can't practice those techniques.
You're right, Dr. Kairam. I mean, I think, if I continue that, definitely that's what I want to do. But I got good amount of insight into the post-COVID through this survey. And I think Dr. Naveen Kumar, as he said, he's, again, I said, most of our colleagues in India, they're seeing all this stuff. They're seeing long COVID. And so good to hear their insights into it. And thank you, Naveen.
Dr. Vijay Sekhar has a question, the last one.
Sir, it is not a question, a discussion sort of thing, Bush. Did you come across any healthcare providers, especially the doctors, staff nurses, and someone like that, who have stress-related issues, especially hyperglycemia? Previously, because I know at least half a dozen people, especially the doctors, who worked significantly in the COVID time, who are absolutely keeping good health, even after this COVID management, they have become diabetics or their blood glucose levels are hyperglycemic. And apart from did you observe any such reports or any?
So these are the doctors who did not get the COVID, you mean, but they're under severe stressful conditions of working under COVID in COVID pandemic era. Is that right?
Yes, yes.
Yeah, I think we always have the stress as a cause of the cardiovascular and also hypertension, and diabetes is also mentioned as a part of that. But particularly hyperglycemia in stressful conditions, I haven't reviewed the literature recently, but for patients with hyperglycemia under stress, we do recommend lifestyle changes, and that doesn't help. So now it's good to see how is their blood sugars now when there is COVID is calmed down.
But yeah, that needs to be studied, I suppose, because COVID has the incidence has come down, but the doctors and healthcare professionals, they still continue to be under stress. Of course, no, though not like in the months of April and May, we have seen a very hectic, tough time really. Actually, as Dr. Naveen was pointing out, there was a lot of aspects from the healthcare professionals regarding those not COVID, they are not the patients of COVID, but the COVID-related management. And incidentally, you were referring to some of the emotional issues. So many of the families, the sons and all, they cannot go and see their loved ones and all. Actually, just to share some of my feelings, sir, can I, for a couple of minutes, just to share my experience? No questions, sir. It is on. Can I, sir?
Dr. Sudhakar, we have a couple more minutes.
Yes, please. Yes, please. Yes, please. Yeah.
Actually, in those peak months of April and May, we used to have many number of deaths in one particular center, especially in Visakhapatnam. Ours is the biggest center of COVID care and COVID management. There were occasions where the ambulances carrying the bodies were waiting for their turn in the burial ground for the funeral and all.
So actually, with some of the NGOs and some Jain associations, I have actually visited the burial grounds also to see if we can do something for the fast disposal. Actually, still they were doing with this wooden and the conventional methods only. We tried for the electrical crematorium. So we have tried actually even with the help of we requested the help from the government, requested from the NGOs. Some of the NGOs came forward, but unfortunately they could not be materialized. So there was a lot of stress from the families, and for hours together they have to wait for their turn in the ambulance. I know 30, 40 ambulances waiting with the bodies near the burial ground. So these sort of things have definitely had a lot of impact in the families. So that is my observation. And you are mentioning a couple of points. See, once the one person succumbs in a center, the rest of the family members, they used to, it was a very common practice to blame that the care is not proper. Similarly, when once their saturations are falling, they wish to take the patient against our advice and take them to other facilities, thinking that the private hospitals may be able to serve better. So a lot of such issues are there. So actually, there needs to be, if a good study is, can be done, as you are initiated some pilot study, exclusive study on the healthcare workers, their experiences, stress and other, maybe we can get some other fact.
Well pointed out, Shekhar. Everything you said is 100% like, close to the reality of what, and maybe we are talking about the tip of the iceberg. Each one of us have our own experiences, and we are trying to cope to the best of our abilities. And I think, I don't know, one of the advantages of being in India, I guess, is that throughout our career, we have exposed to some other kind of situations, but not to this level of magnitude. But I think we do have a cultural protective factors there. And we have to think out of the box. We cannot completely have psychologists, social workers, and working all these things. So if this has to be addressed, there has to be a kind of an understanding between the scientific community and the other communities where they do serve. Like, if you're going to your church, if you're going to your mosque, if you're going to your temple, and they can conduct a kind of a services. Suppose you say, if there is a church, if there is a temple, we are going to offer services and prayers one particular day. We are going to do particular kind of a worship or puja or whatever it is. And this is for the people. And that day, those families can go and they can have a kind of a closure. What we are missing is the closure for this kind of a trauma, and to move forward. And there will be some kids, there will be some young people who would carry this for whole of their life. And as a physicians, we lost our own colleagues. And you yourself were worried, most of us, when you were treating, if I go back, am I going to give it to my family members? Now, it is behind us, we think, but still it can bother. So I think we need to work on this, work together, come up with ideas and implement some small protocols in every setup. Like, Dr. Naveen in the steel plant, he's already now taken up some of these interventions in terms of medication management, whatever it is, and counseling his patients about what to do. So I think if Dr. Sudhakar from the AMC, together we can develop small protocols, not major ones, but how to address it.
Okay. Dr. Sudhakar, I have two quick announcements before you have comments or you end. One important announcement is on the same topic, Dr. Kavuru. I spoke to Dr. Kalpalata Guntupalli this afternoon. She is conducting a survey of stress and burnout of physicians who took care of COVID. Unfortunately, she had a very low response rate. And Dr. Sudhakar, you were able to send the survey to our audience, or she was supposed to send it, or am I supposed to send it?
She said that she had to hold on because she wanted to make certain modifications and then resend them. We've been waiting for that, in fact. If she sends with the modifications, we can circulate them. Actually, I have sent the first one, but again, we had to hold on to that.
I believe it's now done. She had only like 90 responses. And you know, that when there is a low percentage of responses, it's difficult to get published. So I said, I will remind all of you today, if you get a query, a survey from Kalpalata Guntupalli, please take a few minutes to finish it and send it back.
Yeah. Can you please ask her to resend that, so the updated version, so that I can circulate that?
I will do that. The second thing is about 2 months ago, either an AMC graduate or a well-known doctor, a nephrologist, died of dengue while there was initial concern that she had COVID. And it was very tragic. It appears very dynamic young nephrologist dead. So at that time, there was a discussion regarding, yes, COVID is devastating the country, but the other diseases are still there. So next week, our speaker would be somebody who's knowledgeable on the co-infections, co-occurring infections, the other infections, Dr. Cosmina Ziana. Dr. Chilimuri had been speaking to her. They both will be there. So I want to make sure that at least those who are there today log back in, because the other infectious diseases are still plaguing our country like they always do, beyond COVID. It's a good reminder. So Dr. Sudhakar, I'm done.
Yeah, thank you very much, Dr. Kairam. Dr. Cosina was with us earlier also. She spoke once before as well. And I'm sure that that will throw a lot of light on what's happening around here. Now that the fevers are on the rise in this part of the country, and particularly with the dengue and malaria, let us find out as to how they can be differentiated from COVID, and what if both coexisting. And it's good to have her next week. And I profusely thank Dr. Bush as well as Dr. Neelima for having come forward to share their experiences in this forum today. And as usual, Bush has done a phenomenal job in conveying the message so well and loud and clear. So thank you very much, Bush. And thank you all those who have logged in today. Thank you, Dr. Kairam, for conducting it so well. And we look forward for the next week's meeting. Thank you. Thank you all. We end the meeting with that note.
Thank you,
one quick one, Dr. Kavuru. Is it Kavuru or Kavuri?
Kavuru. Bush Kavuru.
The Ravi Kavuri got I at the end.
Yeah, that's off the line. I will tell you about it. Yeah.
Okay.
Thank you, Dr. Sudhakar. Thank you very much.
Good night, and thank you very much for coming on. Thank you. Bye-bye.
Bye.